Welcome to another episode of the Empowered Fertility Podcast, the place where we dive deep into all things fertility. I'm Dr. Brenna Squires, a clinical psychologist and fertility support coach, here to bring you the knowledge, resources, and expert insights you need to feel confident along your journey to parenthood. So let's get started. Welcome to another episode of the Empowered Fertility Podcast. Today, we're zooming in on a part of the body that doesn't get nearly enough attention until it becomes a roadblock to pregnancy. We're talking all about fallopian tubes, what they do, what can go wrong, and what you need to know if you're trying to conceive. We're also going to break down the most common tests used to evaluate tubal health so you can feel more confident and informed on your next steps. And if you find this episode helpful, don't forget to hit the subscribe button and tap the notification bell so you never miss an episode. And I am super excited to be joined today by double board certified OBGYN and reproductive endocrinologist, Dr. Carolina Sueldo. With over 14 years of medical training and nearly a decade of fertility experience, Dr. Sueldo specializes in helping people navigate hormone imbalances, menstrual irregularities, and infertility with a whole person, compassionate approach. So welcome. I'm so glad you're here today.
I am so glad to be here, Dr. Brenna. Thank you so much for having me. I really believe in the whole person approach to fertility. So I loved coming across your podcast. That first episode when you talk about the 5 things that you wish you knew. Oh my gosh, that I hear that every single day in my office. So this podcast is so needed. I love that you're doing it. Thank you so much for having me.
Yes, and thank you so much for saying that, because like you just said, so many people have these things that I wish I knew sooner, and we don't tell it to other people. I had a friend telling me the other day, what are the 5 things that I need to know? And so I just directed her to the podcast because I get that question so many times. So I thought, let me just make an episode all about that.
Yeah.
But today's topic is something that we don't talk enough about, like I said, fallopian tubes.
Yeah.
So before we dive deep into this, do you mind sharing a little bit about why you think this is an important topic to go over?
Yeah, absolutely. So I think that for a lot of us in society, in culture growing up, we hear a lot about this biological clock. Maybe we hear about, PCOS is another trending term, etc. But a lot of patients don't actually understand what is involved in a fertility evaluation. So when we're talking about fertility testing and we're talking about the female partner, there's really 3 things that we're looking at as it relates to the pelvis. Specifically, we're looking at the ovaries, the fallopian tubes, and the uterus. So for those that are watching us on YouTube, you'll see a nice little picture. I love showing this picture to all my patients to give them just a sense of normal anatomy. So the fallopian tubes are noodle-like structures that are connected to the uterus, and then they're otherwise free floating in the pelvis. And they essentially, their goal is transportation. They pick up the egg after ovulation, and then I always think of a car wash, like the noodles of a car wash. So they use these things called cilia to push the egg towards the uterus, where it will hopefully meet sperm and become fertilized and implanted. So what we also know is that a lot of times tubal disease, so if those tubes are impacted, that is actually asymptomatic. Many times the patient has no symptoms. So a standardized part of the fertility evaluation includes checking those fallopian tubes to make sure that they're both healthy and open, because many patients may not know that there's an issue. So until we actually do the test, we're not going to know. Most patients don't have symptoms. Now, sometimes we can have risk factors. So if you've had a history of pelvic surgery where there may have been damage to the fallopian tubes, or abdominal surgery as a child where all the structures are closer together, so there may have been damage to the fallopian tubes. If you had a history of a pelvic infection or a complicated STD, such as gonorrhea or chlamydia, in your past, those could be risk factors for tubal disease. If you have something called endometriosis, that could be another risk factor for tubal disease. So there's many reasons why somebody could have fallopian tube damage or blockage, but not all of them. In fact, many of them don't cause any symptoms at all. So the woman has really no way of knowing.
Wow. And everything that you listed sounds super important. Very important that we would want to evaluate this, but I've noticed that not every doctor does this. Not every doctor prioritizes evaluating or even assessing the fallopian tubes? Why do you think that is?
So I think there's a few answers to that question. I think, one answer is that tubal assessment, depending on the state where you live, is typically performed by a fertility specialist. For
Mm,
example, I practiced for many years in California. Due to the radiation laws for X-ray, the radiologists were typically performing the HSG, or the hysterosalpingogram, which is one of the studies we'll talk about today. And so it's really not the patient's OBGYN, who I always call them, they're the first line of defense. Like, they're the
mm,
ones that are doing sort of the initial ordering, the initial workup, maybe even initial treatment. And the second thing is that the test is a little bit more invasive than some of the
mm,
other tests that might be involved in a fertility evaluation. So, for example, we check hormones. That's a blood test. We have blood tests, every year with our annual. A transvaginal ultrasound, yes, it does go in the vagina, but it is there's no catheters. There's nothing going inside the uterus, and so it tends to be a little bit less invasive. And then if there's a male partner involved, a semen analysis, which again is another non-invasive test. And so that tubal assessment sometimes is left as sort of that last step, just
mm,
because of the invasive nature. And then many times, if the patient doesn't have fertility testing coverage, that tubal
mm.
assessment can actually be the most costly of all of the tests involved.
Wow. And so I hear the things that stand out to me are this is the last step. And if insurance doesn't cover it, people might not even think to do it because they might think it's not covered. It might not be a big deal. What else can we do?
Correct. And then the only other thing I'll add to that is it also depends on the case. So, for
Mm,
example, if it's a young patient, she has clearly irregular cycles, you're concerned about, irregular ovulation, maybe you say, okay, she's young, we try to correct that first. If we can get her to ovulate, we do that for a few months. If she's not pregnant, then maybe we do the additional testing, right? So, really, it is individualized. It does depend on the case. But
mm.
by and large, tubal assessment should be considered a standard part of the infertility evaluation. Yes.
Yes, I completely agree. It should be part of standard, especially since you
Yes.
explained it in the beginning of this episode, where there's a couple of different parts and they all play a role.
Exactly.
And can you go down a little bit more into detail with things that can go wrong, or like break down the difference between a healthy versus an unhealthy
Yeah.
um, fallopian tube?
Yeah. So I'm going to go back to that picture. A picture's worth 1,000 words, so make sure to check out Dr. Brenna's YouTube channel for this one.
Ah,
But if you look at this picture here, you notice again the uterus that we saw earlier, and then those two noodle-like structures. But
mm,
you're going to notice that one is very thin and elongated, and the other one is dilated. It's inflamed, almost looks like a spaghetti noodle versus a sausage. If you're
mm,
visualizing this from your car and listening to the podcast. And so when we talk about tubal disease, there's
mm,
really two key components. One is that tube blocked or not? So is it open or not? If it's blocked, where is the blockage? So is the blockage at the communication with the uterus, or is the blockage out at the end where it's supposed to be capturing the egg from the ovary?
mm.
So number one, is the tube open or blocked? And then number two, is the tube, does it have a healthy appearance or does it have an unhealthy appearance? Is it dilated, damaged, inflamed, etc.? So those are the two key components that we would be assessing when we're looking at that tubal assessment.
So with that, are is this something that you can easily see on just an ultrasound, or there's
Oh,
specialized
great
testing for
question.
this?
Yeah, great question. So a normal healthy tube is not going to be seen on a regular transvaginal ultrasound.
Hmm.
So, on occasion, if the tube is significantly damaged and dilated, it will appear as this sort of separate structure on ultrasound. Even still, typically additional testing is warranted. So, on a standard, normal transvaginal ultrasound, really the fallopian tubes are not being assessed. What
Hmm.
is required is that we inject some sort of contrast media, saline, and we'll talk about those in a minute, to highlight the flow. So can we see the
Okay.
flow of the fallopian tubes? Now, the traditional test that has been done forever, it's the one that I trained on back in 2012, which sounds like a long time ago, but wasn't. is the HSG, also known as the hysterosalpingogram, and it is the most commonly performed test here in the United States to assess the fallopian tubes, okay? And typically what we do is it's done on an x-ray table. And so the patient lays down on the x-ray table. We insert a speculum, just the same exact instrument as when you're having your pap smear. Once that speculum is in place, we then insert a catheter into the uterus. Typically, we inflate a balloon inside the uterus to create a seal, and then we inject contrast medium, iodine contrast. And as we're injecting the iodine contrast, we're taking X-ray pictures. And so those X-rays are going to basically light up the contrast and should hopefully show us what I was showing you in the beginning. They should hopefully show us a normal uterine cavity. So we don't actually see the wall of the uterus, but we see the inside filled with that contrast. And we're hopefully seeing 2 fallopian tubes that have filled up and are spilling freely that contrast into the pelvis. Okay, so that is the traditional means. That is the way that most people are assessing fallopian tube, both patency and health on the fertility evaluation.
And I have a question about that
Yeah,
before we move on with
please.
the HSG. And so with that, I did have another guest on that was talking a little bit about how there are times where you can do both at the same time, and then there are times where you can do one side and then another side to look at different characteristics. Do you ever do that, or have you ever heard of that?
So yes, let me expand on that because I think it might be a little confusing. So the
Mm.
first test, which is a screening test,
Okay.
is what I just described. So
Okay.
we are putting the catheter in the uterus, we are injecting contrast, and we are looking at both tubes because we want to get as much information as possible as we can from that exam.
Okay. So that's a
Now,
screening HSG.
right. Now,
Okay.
let's say you did the HSG, and let's say one of the tubes did not show up to the party. It was blocked. Okay. So,
Okay.
what you can actually do is thread a catheter up here into the connection between the uterus and the fallopian tubes,
Mhm.
and you inject it there. You inject it that way. The reason for that is because sometimes the contrast can be irritating to the uterus. The uterus, remember, is made up of smooth muscle tissue, and so it can contract down. It clamps down, generating what we call a false positive result. So the tube appears blocked, but it's not
Okay.
actually blocked. It's just the uterus is clamping down. So by threading the catheter up into that connection, you're in theory overcoming that potential reason. So if you inject contrast and it's still not flowing, you know that it's a true occlusion.
Okay. And so that addresses, thank you for sharing that because that's a little bit different.
Yeah.
But and that addresses the what if it's blocked versus what if it's open. What if it's not flowing well? So like what if it's inflamed and kind of flowing slowly
Yep.
versus if it's
Yep.
that
Yep.
whole noodle and just streaming through?
Yep. So if you see a dilated and damaged fallopian tube, even if it's open,
Hmm.
the concern is that within that tube there is fluid that is collecting, okay? Because
Mm.
the tube normally secretes has secretions. Those secretions are to help moisten the tissue, to help with transport, etc. If the tube is dilated and damaged, that fluid now becomes inflammatory, and that's been documented. So tubal fluid in a damaged tube is inflammatory. It has interleukins, cytokines, prostaglandins, etc. And remember, that tube is connected with the uterus, and so it's
Yeah.
actually been demonstrated that that fluid is embryotoxic.
Mm.
It is uterotoxic, so it makes the uterus
Wow.
less receptive, and then the fluid can actually push the embryo out of the uterus. So we know
Wow.
in IVF pregnancies, if you leave that damaged tube in place, it actually decreases success rates with IVF by 50%.
Wow, that's a big number.
That's a huge number. So if you see a damaged and dilated tube, even if it's open, it still merits further discussion about what do we do with that tube.
And what do you do with that tube? I'm just curious. I know it's probably
Absolutely.
something
So
better to
the
talk about at the end, but I'm curious, like, what do you do if it's damaged?
Absolutely. So the gold standard for tubal assessment is a surgical intervention known
Mm,
as a laparoscopy.
mm,
That's where we put a camera into the belly. So we actually, the camera goes through the belly button. we inflate the belly with gas, and then we look at the pelvic structures, okay? And we repeat the exam. We actually inject dye. This is methylene blue. It's blue contrast dye, so it's very easily seen with the human eye.
Hmm.
And we try to confirm the findings, because what I always tell patients is whether it's the HSG or the bubble test or the hyphosi exam, any of the ones that we're going to talk about today, at the end of the day, they are all indirect tests. So if they come back abnormal, really we want to be talking about the gold standard, which would be that follow-up laparoscopy to
Yeah.
further confirm what exactly it is that we're dealing with. And so at the time of laparoscopy, if you repeat the exam, and that test is called chromotubation. So
Mm.
literally we're coloring the tube, chromotubation. So if you repeat the exam and you find that that tube is still dilated and damaged, then really the recommendation is to remove that damaged tube because of the impact that it can have and the decrease in success rates.
Okay. And so it sounds like there's different steps that you should be
Yes.
taking. When one step is done,
Yes.
then it should let you know what to
The
do
next step.
next.
Yes.
Because something I
100%.
commonly hear from people is that, well, this showed something and we don't know what to do next.
Sure.
Is that they didn't have that follow up HSG, or they didn't have the laparoscopy
Right.
after that. They didn't
Right.
have that next step.
Right. And listen, I firmly believe in patient autonomy. Not everyone is going to agree to a laparoscopy, and that's
Mhm.
okay. But that's where the relationship with your doctor, and I
Yeah.
loved you use the term health advisor and not decision maker. I love that. And so really that's where your relationship with your physician is going to be so important, and having the discussion about, okay, for my case, for the findings that we saw on the imaging, what is the next recommended step? Why
Mm.
would I do the laparoscopy, or why would I not do the laparoscopy, right? And so every case is going to have a different perspective. And at the end of the day, the patient should make an informed decision around that. And I know informed consent is a little bit of a, cliche term, but I
Yeah.
really truly believe in it, because the patient needs to be empowered to
Yeah.
feel like they're making the right decision.
Yes, I 100% agree, especially when it comes to making choices. Sometimes it feels like in the world of fertility, we don't have those options
Mm,
because options aren't given to us in the way that you laid out with the, okay, what is my next step, or what are the next steps? And then
sure.
why would I do this or why would I not do that?
Yeah,
I feel like sometimes you're just left with one option
sure.
and no whys. It's just, this is your option. Do you want it?
Right. And that's where, again, I come back to, that's where I think the relationship with your doc is so important.
Yes. Yes, absolutely. Going back to the doctor is the advisor, and are
Hmm.
you trusting the advisor?
Hmm.
Is the advisor giving you good information that you feel comfortable
Hmm.
moving forward?
100%.
And so you also mentioned another test. So we have the
Yes.
HSG and the different steps that that could take to be able to help
Yep.
evaluate tubal health. What's the other one?
Yeah. So the HSG is the most widely used exam. So I want to lead with that, with that sentence. But for many years, we've talked about, how can we do this better? How can we make it
Mm.
less painful? Less exposure to radiation. How can we make it easier on the clinics, right? Because when you're doing an HSG, you have to have lead walls, you have to have a certain X-ray machine, you have to have lead vests to do it. I mean, it's a whole sort of setup to be able to execute. And for a time, and there are some practitioners that do this, we were doing something called the bubble test. And essentially what we're doing is a transvaginal ultrasound where we inject a catheter, we inject water, so saline sonogram. Remember, the uterus is normally a virtual space, so it's normally collapsed on itself. When we inject that saline, it allows us to open up the uterine cavity and check the uterine walls. Okay, so a saline sonogram is what we would normally do to assess the uterine cavity. And then there's a certain catheter that's made that has a second channel for air bubbles. And so what was happening is you can actually follow those. If you inject the air into the water, it creates bubbles, that we all know. And so the idea was to create those bubbles and watch them flow through the open fallopian tubes. And the upside was the things that I just mentioned. So decreased pain, decreased radiation, et cetera, et cetera. The downside is that it has a very, very high learning curve for the person doing the exam. The bubbles are very difficult to visualize. It takes a lot of practice. It really takes a very, very well trained eye, and it's typically a very high learning curve to be able to perform that kind of exam. So in the last, I don't know, let's call it 3 years, 3 to 5 years, there has been a new study that has come to market here in the US. Now, it's actually been in Europe for the last decade. So it's been around a lot longer in Europe. Usually happens. But anyway, so it's now here in the US. And what they developed is a foam contrast that can be seen on ultrasound. And so essentially what we're doing is like a saline sonogram, we're putting in the catheter, but instead of injecting saline, we're injecting that foam contrast. And so you're able to visualize that contrast very easily under ultrasound guidance, and you're just looking for that forward flow of the contrast. And the learning curve for it is very small or short, because the contrast just lights right up, right? And so you're able to perform it easily. This has enabled many more providers to be able to do the exam. It's a lot less painful for the patient. It's less, there's no radiation exposure. The recovery is typically a little bit better. So there was many positives and just not a whole lot of downsides. So this is something that here at Ceibo Fertility Center, where I practice, this is something that we've been doing for about 2 years now.
And what is that one called?
So we call it the hyphosis study.
Hyphosi?
Yep. So basically, their histero portion is the uterus, the foci is the foam, and then looking at the tubes, right? So the hyphosis study uses something called XM foam contrast. That's the actual name of the contrast. XM foam. I don't know why they chose that name, but that's the name they chose. And so we're performing the same type of exam, but we're typically
Yeah.
doing it in a doctor's office, in a normal
Oh,
exam room, under transvaginal ultrasound guidance.
that sounds so much easier than the HSG.
Yes. Yeah, it is. For everybody.
For everybody, yeah,
Yes,
because like you
yes,
said,
yes.
for a patient, just kinda going over really quickly the different tests, you just said the HSG, the bubble test, and the hyphosi
Mhm.
test,
Mhm.
but for the patient, the HSG is pretty invasive. So
Mhm.
there is some pain involved for the
Mhm.
patient.
Yeah.
Um, the pain varies depending on the person,
Yeah.
and their body as well as the practitioner who's doing it and their
Mm.
skill level.
Yeah.
And then going down to the newer test, the hyphosi, it sounds like the pain level is so much less and the skill level could be higher because it's easier to do.
Yeah, I would say both. And I would say that, looking at the results, the HSG and the hyphosia are probably very similar.
Okay.
But for the patient experience, it's a much, much better experience.
Yeah, so that's good to know that the
Yeah.
results are very similar because that's one
Yeah.
thing that people would probably ask. I'll deal with
Sure.
the pain if I can
Right.
have better results, but
Results,
if
right.
you're saying that I can have less pain and good results.
Yeah. Yeah, exactly.
And is that something that is common? I mean, you said it's very new to America. So is that something that you think is going to start being added to more practices?
Oh yeah, I mean it spread like wildfire. Once we were able to incorporate it from just a logistical standpoint, how we're executing it from a
Mm,
clinical side, from a billing standpoint, with it, figuring
billing.
out the insurance piece, et cetera. It really started to take off because, again, you don't need all the special equipment. You don't have all
Mm,
the same sort of radiations because, again, it's not just for the patient. It's for, the provider and the team members that are doing those exams every day,
mhm.
sometimes on multiple patients in a day. So yeah, I think that it's definitely something to consider.
Yeah.
We're gathering more and more data the more and more we do it, and all of the data so far seems to be reassuring. So really exciting to be able to provide something new to patients.
Yes, something new that it sounds like it's covered by insurance.
Yes, so there's basically a piece. So the exam itself is covered by insurance.
Mm,
If the foam is not covered by insurance, the patients pay, I believe it's $175.
wow. That is
Yeah.
so much cheaper than an HSG.
Yeah. 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 Now, remember, if you have deductibles, co-insurance, and all that, obviously check with your carrier.
Yeah.
But yes.
So that's very interesting because you've just laid out a couple of differences between the two. where we definitely want to have one of these things,
Sure,
regardless, right?
exactly. So at the end of the day, it'll depend on what your clinic offers, because not
Hmm.
everybody may offer the hyphosi, not everybody may
Yeah,
offer the HSG.
yeah,
And so really what your clinic offers, what you feel comfortable with, what your doctor's comfortable with. So
yeah,
definitely worth having that discussion. But at the end of the day, tubal assessment needs to be a standardized part or a
yeah.
required part of the fertility evaluation before you move into treatment.
What do you mean before you move into treatment?
Right. So let's say a couple comes to me, they've been trying for a year and they're like, okay, we just want to start with like, I just want you to give me some Clomid or something. So, okay, before we do that, let's go ahead
Okay.
and let's have a conversation about the fertility evaluation. And in that fertility evaluation, I'm going to talk to you
Mm.
about tubal assessment. As I mentioned, if there's a male partner, I'm going to be talking about the semen analysis and then obviously looking at hormones to rule out any concerning issues there.
Yes. So before we do, that's what you mean. So before we do anything else, we need to do the full evaluation.
Yeah.
And so, what if the full evaluation comes back that you've done these three tests or one of these tests, and let's say one of the tubes is blocked? Then what do you do?
Yeah, great question. And then it's going to depend on, was the blockage proximal or distal? And what I
Hmm.
mean by that is, was the blockage at the connection with the uterus, so the tube
Okay.
never showed up to the party, or was the blockage distal? So the tube
Mm.
actually filled with contrast, we saw it fill with contrast, but it never spilled out into the pelvis. So when you have a proximal occlusion, many times physicians will give the option, okay, hey, we're going to treat you as if you have this blocked tube, but we're okay to move into treatment. If it's a distal occlusion, then they're much more likely to say, hey, you know what, we probably need to pause, we need to consider the laparoscopy before we move
Mm.
on. ASRM, the American Society of Reproductive Medicine, has a whole practice document on tubal assessment as part of the fertility evaluation. When you have a proximal occlusion, which is again in that connection with the uterus,
Mm.
we say that 60% of the time, if you repeat the HSG the next month, the tube will actually show that it's open. So the
Oh.
proximal occlusion does not have the same translation to pathology that a distal occlusion has. If you have a distal occlusion, so the tube it fills but it never spills, you are much more likely to have true tubal disease. Versus
Mm.
a proximal occlusion, there's a higher chance that it's a false positive and that that tube is actually open.
Okay, so depending on where the blockage is,
Yes,
they might recommend to do the evaluation again, maybe in another month, or
correct.
to do
Or
further testing in the other areas.
yep, yep, exactly. Or if it's a distal occlusion, they may recommend laparoscopy, which is
Okay,
the surgical
laparoscopy.
procedure. Correct.
Yes. And then what if both tubes are blocked?
Mhm. So similar thinking at the top. So again, proximal occlusion, we don't necessarily have to do anything. However, if there is bilateral proximal blockage, so neither of
Mhm.
the tubes showed up to the party, then the patient is committed to going to IVF as her next step, or in vitro fertilization. If
Okay.
it's a distal occlusion, then the patient is going to be recommended more than likely to have that laparoscopy.
Yeah.
If both tubes are blocked and the patient's like, listen, IVF is not for me because of
Mm.
whatever reason, then laparoscopy may be a next step as well.
Okay.
And then if at the time of laparoscopy, the tubes are found to be blocked, then the question becomes, do we take them out or not? So generally speaking, and this is my perspective, so take it as the N of one. If you do the laparoscopy, the tubes are blocked, but they appear normal on
Mm.
visualization, then I will not remove them. If the tubes appear damaged and dilated, then the recommendation will be removal.
Yeah.
If we end up removing both tubes, the patient still can have her own genetic child because she has her ovaries and she has her uterus, but she will be committed to IVF or in
Mm.
vitro fertilization because with both tubes gone, there's no way for the egg and sperm to meet.
Okay. Thank you. Thank you for sharing that. Um, because I know a lot of people are curious about what happens if one's blocked, if both are blocked, what are those next steps?
Mhm, mhm.
And I'm curious if you see things that are damaged. So if you see tubes that are damaged, is there any way that they can be repaired either through diet, like lifestyle changes, or medication, or surgery?
Great. Good question. So the thought is, okay, first and foremost, from a lifestyle and nutrition standpoint, I'm always going to be talking to patients about an anti-inflammatory diet.
Okay.
The closest thing to that that I can think of is the Mediterranean diet. So really just eating whole foods, unpackaged, unprocessed foods. And that's just good at baseline for fertility, period. Okay.
Hmm.
As far as treatment of the tubes you want to think about, their only known function in the body is transport. As far as we understand, there is no other function. And the tubal tissue is so delicate that once it has been damaged, there's really no going back. So we can't really reverse the damage.
Okay.
Now, depending on how damaged the tube is, you may consider something called a fimbrioplasty. And the way I envision a fimbrioplasty, if you think of a banana, and so that banana is dilated and it's closed at the end. So this is a blocked tube that is
Mhm.
damaged. If IVF is not an option, what we can do is actually put a slit at the top of the banana and then peel back the layers, right? So peel back the skin and essentially create a flower to try and open or create an opening for that tube. So a new opening for that tube. Now, tubal surgery back in the 90s was actually the mainstay of treatment for patients with tubal disease because IVF was so unsuccessful. Now, 25 years later, I would say to that patient, there is a very high risk of that tube reoccluding because
Mm.
the tissue is damaged. And so even though we try opening it, you may find that you repeat an HSG or a tubal exam in 2 to 3 months and it closed back up. Or if it stays open, that tube, because those cilia, those car wash noodles are not working properly, then you had a very high risk for ectopic pregnancy. So even if
Mm.
you do become pregnant, you're a higher risk for tubal pregnancy. And so for those two reasons, tubal surgery has really fallen by the wayside in the setting of a visibly abnormal tube. Now, can it be done? Yes. Do some fertility specialists, especially reproductive surgeons, still do it? Yes. But with the IVF success rates as high as they are,
Mhm.
really now the recommendation would be let's remove that as a risk factor and let's just move on to getting this patient pregnant.
Gotcha. And with that, I was thinking about the little banana that you said you're
Yes,
making an opening. Is that opening in the direction of the uterus, or is it in the opening of
right.
the egg? I'm
Toward
thinking of the image you just showed, like
yes.
which side
So
of the
it'd
tube is that
be so
opening on?
essentially here I'm going to put it up close, but essentially you would peel these back and tack it back on itself.
Okay, so the little frembre.
Yep, the fimbriae, exactly. Yep.
Okay, so that's what you would tack back.
Yeah.
Yeah, and then okay, I can see how that would be could be helpful, but then you said that that could increase a risk of an ectopic pregnancy. And I know
Correct.
this is not the thing that we're going to talk about for the rest of the episode, but can you briefly share a little bit about what that is and
Yeah.
the problems that it could cause?
Sure. So, an ectopic pregnancy literally is a pregnancy that is implanted outside of the uterus. So, it is a normal tissue, normal pregnancy, implanted in an abnormal location. The most common location is in the fallopian tubes.
Mm-hmm.
And so, essentially, what happens is that instead of implanting here in the uterus, and remember, I mentioned that the uterus is filled with muscle cells, it's made up of smooth muscle. That smooth muscle is created so that it can expand as the pregnancy grows.
Mm.
The fallopian tube is not. The fallopian tube is made up of glandular cells that are not made to expand. And so, as that pregnancy grows inside the fallopian tube, then it can be a threat to mom. So, this is not a pregnancy that can survive, it cannot
Mm.
grow to full term. And this is a pregnancy that, if that tube ruptures, so
Mm.
if it breaks past the tissue, the mother can actually have internal bleeding.
Mm.
And so, back many years ago, before surgery was an option, many women used to die from ectopic pregnancies. This was a
Wow.
cause of maternal death, untreated ectopics that were basically bleeding internally.
And what could cause that to happen that it would implant in there? Is that just from the inflammation, or is that from the blockage, or is there any other reasons why an embryo would choose to
Yeah,
bury themselves in there?
great question. So, for a certain percentage of pregnancies, we just don't know. So there's a
It
certain
happens.
percentage of pregnancy where the embryo just migrated, even in healthy women with normal
Mm,
tubes. You know, in the general population, we quote the risk of ectopic pregnancy somewhere in the neighborhood of around 2 to 3%. So it's not high, but if it
mm,
happens to you, it can be quite devastating, right?
mm,
Now, in the setting of known tubal disease, right? So when you
okay.
have that dilated tube that I was talking about earlier,
Yeah.
we know that those cilia, those noodles, they're not moving properly. And
Mhm,
so if you think about what happens in a normal pregnancy, the egg is released from the ovary. The
mhm,
sperm is coming up from the vagina to the cervix to the uterus and then goes out. They actually meet in the fallopian tube. Fertilization and
mm,
normal fertilization actually happens in the fallopian tube. And then the embryo, once created, has to then get pushed into the uterus to implant.
yeah.
So if those cilia are not moving properly, the embryo is going to implant where it can and it's going to attach there. So in the setting of known tubal disease,
Mm.
we believe that it is the abnormal functioning of those cilia, those little brushes, that is what causes the risk factor for ectopic
And so that makes a whole lot of sense that if it needs to be moving a certain direction in order for it to be flowing to the
towards
right
the uterus.
place.
Right, right, right.
Where does endometriosis play a role in this?
Great question. So, first of all, for the listeners who may not know, what is endometriosis? So, endometriosis is also the abnormal location of normal tissue. So, every month, a woman sheds the lining of her uterus. That's what we know as menstrual bleeding. In a certain percentage of women, and we don't know why, but in a certain percentage of women, some of that tissue backflows through the fallopian tubes and implants in the pelvis.
Mm,
So those implants of endometriosis are just endometrial tissue, so menstrual tissue that we would normally bleed, but they've now implanted in the pelvis.
yeah.
And they typically have three stages of development. So the red or fresh lesions, when the endometriosis has recently implanted, those bleed every month with a period. That blood is inflammatory. It causes disruption to a highly innervated pelvis. So, you know, one of the most common symptoms of endometriosis is very painful periods because, again, those implants are flaring during menses. Eventually, those implants, they'll coagulate over, so they create black or gunpowder burn lesions. That's always the classic test question for endometriosis. And then eventually, those gunpowder lesions turn into scar tissue.
Mm,
And I always think about scar tissue as sticky bubblegum on a sidewalk. And so it sticks the structures together inside the pelvis.
wow.
So when we stage endometriosis, it's a surgical diagnosis, so it's surgically staged. Remember that laparoscopy we were talking about earlier, where we put a camera in through the belly button? That
Mhm,
allows us to visualize these implants, red, black, or white, and
mm,
we're looking for endometriosis on laparoscopy. The stages are 1 to 4, 1 being mild, just a few implants, and then 4 being just what we call a frozen pelvis, that the entire
wow.
pelvis is just filled with endometriosis, with scar tissue, etc. So as you move into the advanced stages of endometriosis, there is so much distortion from the scar tissue that the tubes can
Mm,
actually be, you know, twisted, pulled, pushed, etc., and can actually
wow.
become blocked. Even though the tube itself is healthy,
Mm,
it becomes abnormal because of the scar tissue surrounding it.
wow. Wow. Thank you for explaining that, because I've never
Yeah.
heard it explained in that detail. But like you had just said with the last one where we have that scar tissue at that sticky gum,
Yep.
between the sticky gum and the scar tissue, and then having the fallopian tubes being bent and the cilia not working. I mean, it sounds like it's such a, a dangerous journey to
For
get
that little
from
egg, right?
this
The
poor little egg.
sperm.
It's a little dangerous journey, let
Yeah.
alone for the sperm to get there. So it's like with all of these different barriers of possibly endometriosis or issues with the fallopian tube, that there's a lot of danger for these two to even meet, let
Mhm.
alone find a good, safe place
Mhm.
to
Mhm.
to bury itself.
Right. Which is, again, sort of circling back to where we started our conversation. This is why tubal assessment is so important as
Mhm.
part of the fertility evaluation,
Yeah.
because most women actually don't know. They don't know that they have endometriosis, or they don't
Mhm.
know that they have scar tissue, or they don't know that they have tubal disease. So it's not until the test is done that we actually then find issues or things going on.
Yes, and that's not something that's easy. As we said, it's not an easy thing where you could just kind of look in and say, "Hey, they're clear," or "They're not clear." You actually have to go in and do specific testing. You have to be intentional about
Yes,
looking for possible damage or healthy fallopian tubes.
for sure.
And is there anything that you can think of? I don't know if this is an odd question or not, but anything that you can think of that improves the health of fallopian tubes that's not surgical?
Yeah, so not that we know of is like the one liner. In terms of once the tubes have been damaged,
Hmm.
there's no way currently that we know of to reverse that damage.
What if they're
Now,
healthy?
right, so that thank you, because that's where exactly where I was going. Now, what I will say is I think that there is a lot that can be done as a preventive measure. For example, you know, regularly protecting yourself against STDs. I think
Mm,
when we're 18, 21, we're not really thinking about our fertility.
yeah,
But I think that's super important to really be aware of that, because, pelvic infections are definitely a huge risk factor.
yes.
If you're going to have any instrumentation, whether it's of the uterus, of the pelvis, you really want to understand what the surgical plan is,
Mm,
what the potential complications are.
yeah,
I can't tell you how many patients I've had who've gone in for a cyst removal and then they ended up losing a whole ovary and a tube and they had no idea that they didn't have them. And, so
my
really
goodness.
just being informed going into any sort of procedure. Those are really, I think, the big things that are going to be important. Now, sometimes it's
Mm,
inevitable, right? If you have, I don't know, I'm going to make something up. If you have ruptured appendicitis and the ruptured appendicitis caused infection in the abdomen and
mm,
pelvis and that created
yeah,
there was nothing you could have done to prevent that.
mm,
But I certainly think taking any steps you can to sort of minimize the risk factors for
mm.
yourself, that's going to be the most important thing.
Yeah, that's good. Thank you so much for sharing that because there are some things that are out of our control completely that we
Right.
don't really know, which is why it's so important to have that evaluation
Yes.
because we don't know to have that evaluation. But like you said, you can prevent the STDs, try to reduce the risk factors for pelvic infections, and then if you are having surgery, because that is common to have fibroids removed
Yep.
or cysts or
Yep.
things like that, but being aware of the risk factors and also asking enough questions to make sure that everything is going to come out healthy as healthy as possible, especially if you're going into it thinking that only one thing is happening. You
For
want to be
sure.
able to come out of the surgery knowing that everything is still good.
Yes. 100%.
Awesome. Well, thank you so much for sharing. I'm trying to see if I have any other questions, but
Yeah.
before we go, do you have any final thoughts or anything else you want to share regarding the health of fallopian tubes or things that people can do to be able to evaluate this better?
So I think, the one thing that I always tell patients is self-advocacy. And I think you do a great job of that on your platform. So I won't spend too much time on that, but just, making sure that you're informed, that you're educated, that you understand. I think that's just such a huge part of the process. And there's nothing wrong with, hey, you know what, doc, I didn't understand that. Can you repeat that one more time? Or I didn't
Mm,
understand this piece or whatnot. So self-advocacy, I think, is a huge thing. Um, and then the other thing I would say is that many times patients are scared to see a fertility specialist. They
mm,
think that seeing a fertility specialist condemns them to IVF. Or they think they need a referral from their primary care, their OBGYN to see a fertility specialist, et cetera. And so I would just encourage patients, and again, this is where your relationship with your physician is going to be so important, but researching the fertility clinic, researching the
mm,
doctors, really understanding who it is that you're seeing, because seeing a fertility specialist does definitely, and I'll speak for myself, certainly here at Ceibo, does not necessarily mean you're going to IVF. It's let me go in, let me get educated, let me get informed what things are being proposed, what things are being recommended, and then I can take that information back, digest and process it, and decide how I want to proceed. So I would just, I would love if there's one takeaway is just removing a little bit of that fear
Mm.
of going to a fertility clinic or seeing a fertility specialist as sort of like the pathway to IVF. Yes, many patients need IVF. It is a great tool in our toolbox and something that I do every day. But I just want to like give a broader definition to what a fertility specialist means to me.
Yes, and thank you so much for sharing that because that is a really big thing in the world of fertility with anxiety about what to do next,
Yeah,
and there's a lot of anxiety about where should I go and what should I
yeah,
do, and there is a big misconception about fertility specialists in that the only route is IVF. And
yeah,
so I appreciate that you shared that because hopefully listeners out there who are fearful of that first appointment may look at it as an evaluation of just opening the doors to
yeah,
other types of tests that can be
yeah,
done and other options. Yes, IVF is an option, but it's
yeah,
not the only option. And that also
yes,
goes into the research. If you're researching the clinic and that's all the clinic does, I mean, then that's not necessarily a bad thing, but that just lets you know that that's what the clinic does. Maybe go
right,
to another clinic that does more
sure,
evaluations or that focuses on something else,
sure,
especially if that's what you're looking for your
right,
fertility.
right, yeah,
Awesome. Thank you so much. I really appreciate you coming on here. I've learned so much and I know the listeners have
good.
probably learned so much as well.
I'm so glad. I'm so glad. Education is a passion for me. I really believe in empowering women around their fertility. So I really hope that people find this episode useful.
Yes, thank you so much. And if somebody wants to reach out to you for a consult or
Yeah.
for anything else, how could they connect with you?
Yeah, so they can find me on social media, under my name, Dr. Carolina Sueldo, or under the clinic name, Ceibo Fertility Center. Ceibo is the national flower of Argentina. That's why I chose it. I am licensed in both California and Florida. So if you're a
Mhm.
California patient or a Florida patient, the office itself is located in Fort Lauderdale, Florida, and our website is ceibofertilitycenter.com. So would love for them to reach out to me. And if you are on social media and do watch this episode, I would love to get a DM about what your biggest pearl was from today.
Awesome. Thank you so much. I really appreciate that. And thank you so much, listeners. I appreciate you. And if you have any questions or comments, feel free to put it in the comment section. And if you have any other ideas for episodes, also put it in the comment section and let me know. And until next time, see you later. Thank you so much for joining me today on the Empowered Fertility Podcast. If you're looking for personalized support on your journey, whether that's through therapy or coaching, please reach out. Just complete the contact form linked in the show notes, and someone from my team will be in touch with next steps. Remember, you are not alone. You are not broken, and your story is not over. See you in the next episode.